This is Randal Schell, and I'm making a podcast on calcium, magnesium, phosphorus, and the anesthesiologist. We'll begin looking at the key words from the ABA ITE dating from 2010 to current 2015 on the topic of calcium, magnesium, and phosphate. You can see that calcium predominates in the number of key words, while magnesium is second and phosphorus is a close third. If you look at calcium, you can see that both hyper and hypoparathyroidism, hypercalcemia, and hypocalcemia predominates. There's questions about electrocardiographic changes related to calcium. There's questions related to damage to the parathyroid or a post-thyroidectomy parathyroid injury with postoperative hypocalcemia. Questions about citrate and its binding of calcium. A few questions related to the physiology of calcium associated with acetylcholine release presynaptically, as well as myocyte ionic flow, probably related to calcium, troponin, tropomyosin function. Some questions related to MH and specifically dantrolene mechanism. With regards to magnesium, hypermagnesemia, there were several questions related to that. Probably magnesium given in an obstetric situation in relatively high doses and some of the potential complications of such. Magnesium can cause electrocardiographic effects, including prolongation of many of the intervals, and when bolus can cause a vasodilatory hypotensive effect in flushing, which is frequently seen in obstetric patients when a bolus is given. Polymorphic VTAC or torsades is treated with magnesium, and patients who are alcoholic for extended periods of time or heavily use alcohol and don't get other forms of nutrition can have electrolyte abnormalities, and magnesium and phosphorus or phosphate are characteristic ones. If a patient doesn't have adequate phosphate, the ATP levels inside the cell can be low, and energy deficient states can result in muscle weakness, and we'll touch on those. So as an outline, we'll talk about calcium first, both low and high, magnesium second, both low and high, and phosphorus third, both low and high. So starting with calcium. Most of the calcium in your body is in the bone, stored there, and when you look at the ratio of extracellular to intracellular calcium, there's much more extracellular, and there's a gradient from the outside to the inside. We utilize calcium to move into the cell, and when it does so, it has effects such as cross-linking of troponin, tropomyosin, and muscle fiber movement is one example. Circulating calcium is bound to albumin, almost half of it, 40%, but 50% of it's in the ionized fraction. This is very important because the ionized form, not the form bound to albumin, but the ionized fraction is the active form. And that's what we should be measuring directly. That's what is the homeostatically regulated component in our body. And it is altered by the pH of our body, whether it's alkalotic or acidotic. This can change the ionized fraction calcium levels. So if we look at plasma calcium, the normal is shown here. Albumin levels will affect total calcium concentrations because remember about 40% of calcium is bound to albumin, but the albumin concentration does not affect the ionized calcium concentration. So it's the total, not the ionized, affected by albumin. It's the ionized that is affected specifically by plasma pH changes. And in fact, the easy way to remember this is that alkalosis, which has LO, low, in its name, causes a low calcium. It also causes a low potassium. Alkalosis decreases the ionized calcium. Acidosis can increase the ionized calcium. Now, calcium is essential for multiple things. It's essential for excitation contraction of muscles, neurotransmitter release, specifically presynaptic calcium moves in and acetylcholine is released, blood coagulation at multiple levels, hormone secretion and enzyme secretion. When we give drugs like epinephrine, dobutamine, and expect to have a beta effect, The beta receptor, when it's activated, cyclic AMP is a second messenger, and calcium usually is the end result. It increases intracellularly and has its effect. The cardiac pacemaker cells and the cardiac action potential are affected by calcium also. So calcium is very important in our body. And let's look at this graphically for just a moment. I think it's easier to remember when you see things in pictures sometimes. So up at the top left is a presynaptic neuron showing calcium coming in presynaptically, acetylcholine in the little vesicles being released, so calcium is associated with presynaptic release of acetylcholine. And this is one of the points where magnesium will interfere with calcium effect and can cause potentiation of non-depolarizer and depolarizing muscle relaxants. Also, calcium in the second picture here is associated with beta agonist activity. If a beta agonist comes in, binds to its receptor, cyclic AMP goes up inside the cell, calcium goes up inside the cell, and, for example, contraction may increase. So, second messengers and calcium intracellularly, the movement of such is important. With coagulation, top right, prothrombin to thrombin, calcium is associated. Fibrinogen to fibrin, calcium is associated, so it is important for normal coagulation. At the bottom left, you can see the breakdown of ATP and cross-bridge movement of troponin and tropomyosin and calcium's role in such. And then in the bottom two, you can see first the ventricular myocyte action potential and showing where calcium is involved, keeping that ventricular myocyte action potential going for a while and the muscle contracting rather than looking like the SA nodal action potential, where you can see calcium in blue here at the bottom being involved in the initiation of that SA nodal action potential. How do we regulate extracellular calcium? Well, parathyroid hormone is number one. Parathyroid hormone comes from our parathyroids embedded in our thyroid gland. And also, regulation of extracellular calcium is associated with vitamin D. The more vitamin D we have, increases calcium. Calcitonin decreases calcium. So on the bottom right is an example of if you take lots of calcium in your diet, in this case it's showing milk and cheese, the calcium is absorbed from your gut, a large amount of it, and plasma calcium can be affected by our diet. It also in this graphic shows calcitonin, which can make plasma calcium levels go down as it moves calcium from the plasma into our very large store. Remember that 98% of our calcium is in the bone. And parathyroid hormone, if calcium levels go down and we need more parathyroid, or we need more calcium, then parathyroid hormone levels will go up and we'll have calcium moving from the bone into the plasma, raising our plasma levels. So we have calcium entering the extracellular fluid from our GI tract and reabsorption from bone, and it can leave the extracellular fluid by being deposed back into bone, excreted in the urine, and secreted into the GI tract. For those who are really interested in calcium homeostasis, I provide you with this graphic, which is way in more detail than is probably necessary. However, it is nice to see that what happens when serum calcium at the top left falls, parathyroid hormone goes up, and you can see how it has an effect on the kidney, it has an effect on the bone, and the end result being enhanced absorption of calcium, calcium leaving bone and going into the plasma, and more calcium being resorbed from the kidney. So calcium excretion is reduced and serum calcium levels go up. As opposed to if your calcium is very high, what happens is that you have parathyroid hormone is going down, you have stimulation of calcitonin, which results in a deposition of calcium back onto the bone, and our serum calcium levels go down. And there's some other effects too. Causes of hypocalcemia. Surgical damage of the parathyroids is one. When thyroid surgery is being done, if devascularization of the parathyroids occur, postoperatively hypocalcemia can present. Severe hyper or hypomagnesemia can result in calcium problems. In fact, if your magnesium is very low, you have suppression of parathyroid function, and so your PTH is not going to go up. So this may be a cause of hypocalcemia. So oftentimes these electrolyte disorders are presenting together. So think hypocalcemia and hypomagnesemia together potentially. Remember that calcium is traveling around attached to albumin, and it's the ionized that we're really interested in. Alkalemia, such as that can result from hyperventilation or bolus administration of bicarbonate, can result in changes in ionized calcium. Remember, alkalosis results in lowering of the calcium level. Phosphate and calcium often go in opposite directions, and as phosphate goes up, calcium goes down. Overzealous phosphate administration can result in hypocalcemia, and rarely citrate toxicity. Although it's talked about, it is rare unless you're giving extremely high rates. If it's a normal patient, extremely high rates of citrated blood or FFP. Remember that FFP has citrate in it as well as packed red blood cells. That citrate binds calcium, preventing coagulation of that product. And if you give it to a patient, the citrate binds calcium within the patient. When it chelates the calcium, coagulation will not work as well, and you have what's called citrate toxicity. This is very uncommon. If a patient, however, has severe liver disease and can't metabolize the citrate, is very cold and the liver is not functioning very well, or, for example, one of the classic ones is the anhepatic stage of a liver transplant, where you're giving blood products and FFP, the liver is not present, either the recipient or the donor yet, liver is in place, you're truly anhepatic, you can get into problems with citrate toxicity. Other things like hypoparathyroidism, vitamin D deficiency, precipitation of calcium, and pancreatitis and fat necrosis that occurs, you have like soapy formation with calcium binding to it, and calcium levels can go down in pancreatitis, and fat embolism, and rhabdomyolysis. But the most common ones that we think about in the perioperative period are parathyroid injury, pH changes, and citrate. So if hypocalcemia occurs, what are some of the clinical manifestations? In the heart, there can be electrocardiographic changes, the characteristic finding being a prolonged QT interval with hypocalcemia. The heart muscle needs calcium to function properly, and heart failure can occur as evidenced by elevation in filling pressures and hypotension. The muscles become twitchy and spasms and tetany, especially if you do things like the Shaw's-Steck or Trousseau's sign, blood pressure cuff on an extremity, tapping on the forehead in a specific location, and the muscle spasms. And there can be even laryngeal spasm, and that has been associated with post-thyroid surgery where the parathyroids have been injured, and laryngeal spasm many hours after surgery is completed has occurred secondary to hypocalcemia from parathyroid injury. Now, the electrocardiographic changes of hypocalcemia we think of characteristically as being a prolonged QT interval, and that is shown down here in the black arrows showing from the QRS to the T. There's a prolongation of that, but this is not a consistent finding. However, this is what electrocardiographic changes we most often associate with hypocalcemia, a QT prolongation. What are the cardiovascular effects of IV calcium? If someone's hypocalcemic and you're wanting to give them calcium, well, first of all, if it's just a mild ionized hypocalcemia, we probably should not be treating that. And after cardiac surgery, if we administer calcium, usually what we see is an increase in blood pressure. And in dogs, if you give a normal calcemic dog calcium chloride, it primarily acts as a vasoconstrictor, while in hypocalcemic dogs, if you give calcium, it'll improve contractile function as well as the blood pressure. So if you have normal calcium levels and you give someone calcium, you probably should think of it as a vasoconstrictor, while if you have low calcium, it will vasoconstrict as well as increase myocardial function, likely. Now, calcium can be given as the chloride or the gluconate form, and it's important to remember that the gluconate form contains only about a third as much calcium in it as does the chloride form. Some hypocalcemia in the anesthesiologist summary points. The first one is the citrate issue. Remember that citrate that is in blood and FFP can bind calcium and have problems with citrate toxicity, which would be symptoms of hypocalcemia, hypotension, decreased myocardial contractility, increased filling pressures in the heart, coagulation issues, etc. Classic electrocardiographic change of hypocalcemia, QT prolongation. The fact that electrolyte abnormalities often occur together, and if a patient's hypomagnesemic, it impairs parathyroid hormone secretion. Remember that parathyroid hormone is released from the parathyroid and causes the release of calcium from the bone into the plasma. And so if you have a low magnesium level, your parathyroid hormone secretion is impaired, and your calcium levels may not come up like they should. So you need to treat the magnesium problem as well as the calcium problem. And if you treat the magnesium problem, it may correct the calcium problem. Phosphate and calcium interactions are often present. Chronic renal failure is the good example of that, where patients are hyperphosphatemic, and when they're hyperphosphatemic, high phosphate that is, these chronic renal failure patients are often taking medications to bind the phosphate, and they're often taking supplemental calcium. Aluminum hydroxide being one of the medications to bind phosphate, and calcium supplements to raise the calcium levels. And so, since phosphate and calcium often go in opposite directions, as the phosphate goes up, the calcium goes down. So the phosphate may be the cause of the hypocalcemia. If a patient has low calcium, response to neuromuscular blockade can be impaired. Now you would think that if calcium was low, that it may result in sensitivity to neuromuscular blockade, but the response is inconsistent. Calcium channel blockers can potentiate neuromuscular blockade. Now with regards to IV administration, I pointed out earlier that if you're going to give IV calcium, it can be given in the chloride or the gluconate format, and just remember that the gluconate is a third the amount of calcium that you're actually given than if you were given the chloride form. Malignant hyperthermia are one disease in anesthesia. Remember that it's calcium mediated. The picture at the bottom right shows that. In fact, what it is showing is the sarcoplasmic reticulum, a ryanodine receptor, and remember the defect is here, and when there is exposure to inhaled anesthetics plus or minus succinylcholine, we can get calcium release from the ryanodine receptor and sarcoplasmic reticulum intracellularly, such that high, super high calcium levels occur, actin myosin filaments cross, rigor of muscle occurs, heat production occurs, CO2 is produced, lactate is produced, and the classic findings of malignant hyperthermia. Dantrolene blocks SR, sarcoplasmic reticulum release, and does not block reuptake. So the mechanism of dantrolene, blocking the release of calcium from the SR and allowing the continued uptake such that intracellular calcium levels decrease. Let's move on to hypercalcemia now. Etiology, hyperparathyroidism could be one cause. The parathyroid hormone is secreting a lot of its product, PTH. PTH causes bone to resorb and calcium levels to go up. The primary problem with parathyroid, or a secondary problem. Example being chronic renal failure, and in that case, parathyroid hormone can be up because of the chronic renal failure. Remember, phosphate goes up, and calcium goes down, and the PTH can go up in response to the chronic hypocalcemia. Cancer is also another classic one. It can be secondary to bony destruction, where someone has extensive metastatic disease, bone being destroyed, calcium levels going up, or the cancer itself may be producing humoromediators that are resulting in increased calcium. Other examples, Paget's disease, benign disease in which you have increased turnover from bone. And then another example is chronic immobilization. A quadriplegic patient, for example, can have hypercalcemia. Now, if the hypercalcemia is moderate, and by definition that's a total serum calcium here of about 11.5 to 13 milligrams per deciliter, the patient may be lethargic, not want to eat, may be nauseated, and may be urinating a lot. And then when it's really high, and by definition of severe hypercalcemia greater than 13 milligrams per deciliter, this is a medical emergency. The patient's muscles are weak, they can be stuporous, in a coma, severely hypertensive, they can be in heart block, have lots of dysrhythmias, go into cardiac arrest. And if by chance they were receiving digitalis at the same time, they can have a digitalis sensitivity. Now, the classic finding on electrocardiogram is just the opposite of hypocalcemia finding. That is, instead of a QT prolongation, there is a QT shortening in hypercalcemia. That's a relatively classic finding. So if it's severe hypercalcemia, and how do we treat it? Saline infusion, giving normal saline, a large amount, dilutional, helps you get rid of the calcium and dilute it. And if you give furosemide or Lasix at the same time, you can get a calciuresis and excrete the calcium. And that's usually effective, saline and Lasix together. Occasionally you have to give drugs like bisphosphonates that inhibit the osteoclasts in the bone, or calcitonin, which helps put it back from the plasma into the bone, mithromycin, which inhibits osteoclasts, or if it's really, really severe, you may have to move right to dialysis. Switch gears now from calcium and move on to magnesium. It's the second most abundant cation in the body. It is, unlike calcium, it is intracellular. Remember, calcium was mostly extracellular, the gradient. Magnesium's intracellular. And what's circulating in the serum is only about 1% or less. And the remainder of it's in the bone and the soft tissue. So what we measure when we measure magnesium levels is a poor reflection of actual tissue levels. And also, ionized magnesium makes up about half or so of the total magnesium. We absorb magnesium in our small bowel, and our kidney can excrete it or absorb it. In normal, serum magnesium is approximately 1.7 to 2.1 milligrams per deciliter. So the take-home point is it's intracellular, and our serum levels do not reflect our tissue levels very well. Where does magnesium work? Lots of places. One, it's important in enzymatic function. It's important as a regular cofactor in things like the sodium-potassium pump, the adenyl cyclase, proton pumps. Magnesium, that is, tends to do the opposite of what calcium does. It's a calcium antagonist. And for example, presynaptically, magnesium in high levels will inhibit calcium movement presynaptically, and by doing that can reduce the amount of acetylcholine that is released presynaptically, and one of the mechanisms of potentiation of neuromuscular blocking agents. Potassium metabolism. Magnesium is important in the sodium-potassium ATPase and potassium entry into cells, and potassium reabsorption by the renal tubules. So if you have someone who is hypomagnesemic and hypokalemic, you really need to replace their potassium also. It also blocks the release of catecholamines from adrenergic nerve terminals, and it antagonizes NMDA receptors. Remember, ketamine is the IV induction that works at the NMDA receptor. Magnesium has an action at the NMDA receptor. So where's the clinical uses of magnesium? One, in OB as a tocolytic hypotensive agent. When you give it, what happens is you can get vasodilatation, and the patient who receives it will have flushing, and this is common with an IV bolus. Now, magnesium use in OB is usually used in the preeclamptic patient and in an attempt to reduce seizures. In the past, used for both tocolysis and seizure reduction. But when it's given to someone, just remember if it's pushed rapidly, that it can cause vasodilation. Cardiac dysrhythmias, when do we use it? On the middle right, you can see wiggly lines, which is supposed to represent torsades de pointes, or polymorphic, many different forms, ventricular tachycardia, as opposed to ventricular tachycardia that is monomorphic, or singular form. Torsades de pointes is often associated with hypomagnesemia, and magnesium is one of the treatments for it. Ventricular arrhythmia is related to dig toxicity. Sometimes magnesium is given in the postoperative period to reduce rhythm disturbances after a heart surgery. And in the patient who is hypokalemic and has insulin resistance, magnesium can be supplemented. I've given a reference here that you may want to go to, although it's relatively old at this point. Still, it's a pretty good reference on therapeutic use of magnesium in our specialty. Hypermagnesemia, how can you get it? Well, iatrogenic is one cause, and that is magnesium sulfate therapy in obstetrics, excessive intake with antacids or laxatives, or renal impairment or some combination of excessive intake with renal impairment on top of it can result in high magnesium levels. The manifestations of hypermagnesemia are 1, hyporeflexia, 2, sedation, 3, weakness, and potentially respiratory arrest. So neurologic. And remember, up on obstetrics, when magnesium is being given, the reflexes are followed, and if a patient becomes hyporeflexic or areflexic, we start thinking, how high are the magnesium levels? Are they too high? So monitoring the reflexes is one way to monitor for hypermagnesemia in obstetrics. Cardiovascularly wise, we already mentioned that an IV bolus of magnesium can result in vasodilation, and hypotension can result. So several grams given rapidly of magnesium can result in hypotension. It also can widen many of the intervals of the heart. And the next slide shows some of these effects of increasing plasma magnesium levels. And specifically, if you look at the therapeutic range for obstetric use of magnesium is about 4 to 8 milliequivalents per liter here in this graphic. You can see that this overlaps actually with electrocardiographic changes, some of the interval prolongation and widening of the QRS. So at therapeutic levels, you can get electrocardiographic changes during therapeutic use of magnesium for obstetrics. However, when you lose deep tendon reflexes, it's way up there at about 10 milliequivalents per liter, and then heart problems and respiratory arrest occur at much higher concentrations, and cardiac arrest at even higher ones. How do we treat hypermagnesemia? If the patient has neuromuscular and cardiac toxicity, you can acutely treat the high magnesium levels with intravenous calcium. It's a transient antagonism of some of those effects, toxic effects, but you can get rid of magnesium by giving, again, saline along with Lasix. And if it's really bad, magnesium levels are super high, and you have neuromuscular cardiac toxicity, dialysis in patients that can't respond to the saline and the Lasix. And remember, at the bottom here in italics, I put, be cautious of neuromuscular blocking agents with hypermagnesemia. The classic being that obstetric patient, again, on magnesium infusion for preeclampsia, comes for cesarean section. If you use either succinylcholine or a non-depolarizer neuromuscular blocking agent like rocuronium, magnesium antagonizes the release and effect of acetylcholine at the neuromuscular junction, will potentiate both non-depolarizer and depolarizing muscle relaxants. Let's move now to low magnesium levels. How can you get low magnesium levels? Classically, the alcoholic patient who just isn't getting much nutrition and vitamins and minerals and electrolytes, but is getting all of their caloric intake with alcohol. And the one that we see frequently is the critically ill patient. Apparently up to 50 to 65% or so of critically ill patients are hypomagnesemia, or have low magnesium levels while they're in the ICU. And prolonged NG suction, intestinal drains, fistulas of the GI tract, biliary system can result in magnesium loss. And usually the patient's asymptomatic, but it can be associated with hypocalcemia. Remember, magnesium is something that is used by the parathyroid gland to facilitate release of that hormone in response to hypocalcemia. So if you have magnesium levels that are low, your parathyroid hormone secretion doesn't work very well, and so you're not going to fix the hypocalcemia as fast. And also hypokalemia associated with hypomagnesemia, if you have renal potassium wasting, and also it's frequently associated with hypophosphatemia. So these combined electrolyte disorders, we often need to think of replacing potassium, magnesium, and calcium, and phosphate, but sometimes we can replace one and then the other one will take care of itself. If the patient is hypomagnesemic, they may have cardiac irritability, increased dysrhythmia such as AFib, prolongation of some of the intervals. Thing to remember, don't administer magnesium real rapidly. Several grams over a short period of time can result in hypotension, mainly due to vasodilation. Lastly, let's finish up with phosphorus balance. Phosphorus is often in the form of inorganic phosphate. It is the most abundant intracellular anion. Now, when you think about ATP and DNA having phosphorus in it, then you can understand why it's so abundant intracellularly. Most of it's in bone, just like calcium. And the free ion is, again, about half of it is free. Some of it is protein bound. Phosphorus uptake occurs in the bowel, and vitamin D enhances that uptake. Phosphorus is excreted in the kidney primarily, and parathyroid hormone augments renal excretion. So as parathyroid hormone goes up, that's going to increase calcium reabsorption, but augment excretion of phosphorus. Normal phosphate levels listed here, 2.7 to 4.5. Where does phosphates work? Well, it's the energy bond in ATP, creatine phosphate. The second messenger systems, such as beta receptors, use the cyclic AMP system, and there's a phosphate there, phosphoinositides, so messenger systems within our cells. Nucleic acids, our cell membranes have it, and 2,3-DPG, diphosphoglycerate, that molecule that promotes release of oxygen from hemoglobin molecules, such that when it's in high levels, there's a right shift. When it's in low levels, such as in transfused blood, causes a left shift where oxygen isn't delivered as well. So lots of actions and functions of phosphates. Hypophosphatemia, low phosphate, if you don't have a lot of it around intracellularly, you don't have much cellular energy, because remember, it's ATP that has a lot of the phosphate associated with it. So cellular energy depletion occurs with hypophosphatemia. This is common in postoperative and traumatized patients. There can be several reasons for it. One, there can be shifts in compartments, and alkalosis is one of those examples of shifts in phosphate. If you fast a patient and then give them carbohydrates, if you give insulin to a patient, there can be shifts in phosphate. There can be a negative balance associated with hyperalimentation, such as TPN. This was one of the key words on the ITE. You start TPN and not give it enough phosphate, and hypophosphatemia can result. Diabetic ketoacidosis, alcohol withdrawal, and excessive loss from either the GI or the renal systems. If it's very severe, low phosphate, you can have low ATP, so the muscles aren't going to work as well. You're going to be weak, the heart's not going to function as well. 2,3-DPG levels are low, so you've could have a left shift of the oxyhemoglobin dissociation curve and impaired oxygen delivery to the tissues. Interestingly, the white blood cells and the platelets don't function as well, and if your respiratory muscle functions are not up to par, you can have respiratory failure. So now let's go to high phosphate, and a cause of high phosphate, one of the more common ones, is renal failure. Remember, in renal failure, phosphate goes up and calcium usually goes down. Also, hyperphosphatemia can be due to increased intake for whatever reason, increased movement out of cells, such as cells lysing and dying from chemotherapy and rhabdomyolysis. For example, the patient that has had a long operation, especially like bariatric surgery in one position for a long period of time, they can have rhabdomyolysis, and you'd expect CPK levels to go up, potentially phosphate levels also, and then hypoparathyroidism as a cause. Number one is renal failure, however, and it is that marked hyperphosphatemia. The kidneys just aren't getting rid of the phosphate that is thought to be associated with lowering plasma calcium by precipitation of it and deposition of it in bone and soft tissue. And so those renal failure patients are frequently given phosphate binding agents like aluminum hydroxide and calcium supplements. So the treatment of hyperphosphatemia then would be just eliminate the cause of the increased phosphate. If it's coming in through the diet, if it's a kidney problem, you're going to have to potentially give phosphate binding agents. But remember, correct the associated hypocalcemia at the same time. So if we go back as we finish up here to the keywords, you can see that we covered most of these topics, going through them. You remember that hypocalcemic electrocardiographic effects is QT prolongation. You know that post-parathyroidectomy, many hours after a parathyroid, you can have hypocalcemia with muscular tetany and even laryngospasm. FFP as well as packed red blood cells have citrate in it, and if given at rapid administration volumes, they can result in citrate binding, that is citrate levels that go up, and calcium binding, and all that citrate binds calcium, and then the patient's hypotensive, the heart doesn't work as well, and the coagulation system doesn't work as well. The acetylcholine release was probably related in this IT keyword to calcium's effect presynaptically on and its opposing effect by magnesium on release of acetylcholine. Dantrolene, we said, was at the sarcoplasmic reticulum, stopping the ranitidine receptor from spewing out calcium but not blocking the reuptake of calcium in malignant hyperthermia. Hypermagnesemia, most common causes tended to be iatrogenic, giving a lot of magnesium, for example, in OB for preeclampsia. And we said in the cardiac system, it caused electrocardiographic changes like prolongation of some of the intervals, even at therapeutic levels of magnesium, and if bolused, hypotensive vasodilatory effects. Torsades de pointes is often associated with hypomagnesemia, and magnesium, several grams, may be used to treat it. And alcoholism, where you're not taking inadequate magnesium or phosphate, can result in low magnesium and low phosphate levels. And if you have low phosphate levels, ATP is low, and you're going to have muscle weakness. So I hope that you've gone through this and learned a lot about calcium, magnesium, and phosphate. And I leave you with one picture. Just recently, I went to northern Italy and had one of those moments that you dream of and you wish for. And in this case, it was bicycling in the Dolomites, climbing the mountains. And this is a picture looking towards the Dolomites. I hope you have a wonderful day, and thank you for listening.